Welcome everybody, and thanks for joining us for tonight's General Practice Information session on LUMOS. My name's Katie Pryor and I'm the Manager of Education Programs here at the Western New South Wales PHN. I would like to start tonight's meeting by acknowledging the traditional people of the Wiradjuri Nation as I sit here in Bathurst, and all the nations and traditional lands on which people here sit tonight. I pay respect to elders past, present and emerging, and acknowledge their continuing connection to land, water and culture, and for their contribution to help shape the life of the communities in which we work and live. We are committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social well-being. I welcome Aboriginal and Torres Strait Islander Australians who are present in this meeting. I'll just run through a little bit of housekeeping. This webinar will be recorded tonight and will be available on our website. It's usually within a day or two, and it's under the Events and then Webinars tab. Whilst everybody is on mute to optimise sound quality, we do welcome any questions that you have, so please type them and any comments into the question pane in your control panel, and our presenters will address them at the completion of their presentation. Sorry about that, I've got ahead of myself. I'm sure you've had some time to read our presenter bios before the webinar started, and I would like to warmly welcome Adrian Power, who is the Collaboration Lead for LUMOS, and Genevieve Langron, who is a Senior Project Officer for LUMOS at the New South Wales Ministry of Health. And I will now pass over to Adrian to start their presentation.
Thank you.
Thanks, Adrian.
Okay, let me share my screen.
Brilliant. That looks perfect.
Hopefully, perfect. Okay. Well, thank you very much, Katie, and thank you very much to everyone who's joined us tonight for this introductory and overview presentation about the LUMOS program. So what I would like to start with is a quick overview of what you can expect from tonight's session, and please feel free to send through your questions and comments, and we'll collate those, and there'll be plenty of time at the end to address any questions you might have. So we'll start with a bit of an overview and the benefits to especially general practices for participating in LUMOS, an overview of the reports and key insights that you would receive from participating. And as I mentioned, plenty of time for discussion and questions at the end. So by attending this session, you'll hopefully walk away with an understanding of the benefits of data linkage and some of the resulting outputs, like the practice reports that we'll go through, and identify opportunities of how you might apply that information in your general practice. So what is LUMOS and why are we doing it? Well, we know there's opportunities to improve the patient experience and outcomes across the healthcare continuum between primary and acute care, especially. But in order to do that, we need to understand what patients need, where and when. And without a system view that incorporates the patient journey across primary and acute care services, we're all managing in the dark. So LUMOS is a pioneering initiative that sheds light on that patient journey across the health sector by linking de-identified data under ethical approval between general practices and ambulatory and acute care in New South Wales. So I'll hand over to Jen just to give a bit of an overview of the general practice participation in LUMOS in New South Wales to date.
Thanks, Adrian. So for the next 2 years, we're anticipating that LUMOS will generate insights on up to about 4 million patient journeys through the whole New South Wales health system, And I'm sure you can all appreciate how much of an enormous opportunity this is, and the great potential it has to inform and underpin the transformation of patient care in New South Wales. As of tonight, we've got 262 general practices participating, which is 9.2% of all general practices across the state. And that represents about a quarter of the New South Wales population. And you can see on the right-hand side there, the distribution of participating practices across the state. And we're really starting to build up representation of rural and remote practices as well as metropolitan, which is really important for having a data asset that represents all different population groups across the state. And next slide, please, Adrian. So LUMOS actually began in 2016 as a pilot program with 1 PHN and 5 general practices participating, and it transitioned to statewide scale up early this year with all PHNs participating. You can see on the right-hand side the number of participating practices that have joined the program over the course of this year. And it's really exciting seeing such a steady growth over the year, even with all the enormous challenges that practices have had to deal with this year with the pandemic and bushfires and everything else. So that's been really exciting to see. Back to you. Thanks, Adrian.
Yeah, thanks very much, Jen. And I think it's worth pointing out that practice participation is certainly voluntary, and LUMOS wouldn't exist without the participation of general practices across the state. And really, one of the major drivers for that participation is the excellent level of engagement from primary health networks and the relationships that PHNs have across the state with general practices. So I invite you at the end of this presentation, if you are interested in participating in LUMOS, to reach out to your PHN colleagues to express your interest, and I'm sure they'd be happy to help you with that. So just a couple of key points around the governance of the program, which I think are really important. So LUMOS has ethical approval, and that approval is based on the de-identification of the data and the strong privacy controls that we have in place, and the significant benefit to the public from this work. And we have a waiver of individual consent. So to participate in LUMOS, there's no need to consent individual patients. Consent is at a general practice level, which makes it nice and easy. As mentioned, we have invested in some very innovative technology from Curtin University that allows us to do a privacy-preserving record linkage. And essentially what that means is we can conduct a very high-quality data linkage with encoded or de-identified information that's just as accurate as if we had identified information. So really innovative from the perspective of patient privacy. And to build upon that, we've developed a very secure centralized cloud solution, which we call the SAFE, to safely store the data, the secure analytics primary health environment, and make it available to appropriate people. And finally, we have very strong data governance framework and oversight, as well as other program committees, for example, a stakeholder and an implementation committee that has representatives from general practices, PHNs, local health districts, New South Wales Health, health consumers, Aboriginal community members, and folks from the RACGP and the AMA. So there's a lot of eyes across the governance and the implementation of the program. And most recently, we've had an independent privacy impact assessment conducted by the former New South Wales Deputy Privacy Commissioner. And I'll just read the quote because I think it's really important, which is, "We believe that the LUMOS program deserves to enjoy a high degree of social license, given the significant public benefits expected to accrue from the operationalization of insights derived from the LUMOS data asset and the very low privacy risks posed to individual patients." So with that, again, I'll hand over to Jen to take you through the next section.
Thanks, Adrian. Over the past 6 to 8 months, we've really started collaborating with Aboriginal representatives to understand how LUMOS can best benefit Aboriginal people, given that they are such a priority population across the state. A few weeks ago, we submitted an ethics application to the Aboriginal Health and Medical Research Council to firstly support participation of Aboriginal medical services in our program, and also seeking approval to report our findings by Aboriginality. So if that's approved next year, we'd be able to break down our LUMOS insights, for example, between Aboriginal people in regional areas and Aboriginal people in metropolitan areas, to really understand the patient journeys in specific subgroups of Aboriginal people, so that improvements and initiatives can be targeted as effectively as possible in this population group. We've had extensive collaboration with the Centre for Aboriginal Health, AHMRC, PHNs, and I'd really like to thank Sonia for collaborating with us recently, given that there is such a high population of Aboriginal people in this PHN. And your insights have been invaluable, Sonia, and thank you for your support so far with this piece of work in LUMOS. Next slide, please, Adrian. So we'll be starting to collaborate with some of the CEOs in the Aboriginal Medical Services in Western New South Wales PHN to really understand what they would benefit the most from LUMOS and what barriers they're currently facing with participating. And we're hoping that will help us develop some strategies to make it as easy and as positive for Aboriginal medical services to participate, so they can get as much as possible out of the LUMOS program. We're also looking into creating an Aboriginal project advisory group if we do get that ethics approval. So that group would be mostly made up of Aboriginal stakeholders, and they would be guiding what sort of insights are most appropriate and most relevant for us to be developing from an Aboriginal perspective. Thanks, Adrian, back to you.
Thanks, Jen. So I won't dwell too much longer on the project governance, but you can certainly see the investment that's been put in place to making sure that it's very comprehensive, and in some of the materials that are available, for example, the GP information pack, there's a version of this information in there that you can refer to. So we've been talking about a data linkage project. So what does that actually mean? Well, the cohort really are the patients who visited the participating general practices, and we're doing data linkages currently twice per year in April and October. And a question we always get is, well, is it possible to link more frequently? Right now, the linkages take about 4 to 5 months from data extraction to linkage to processing. So right now, twice a year is the current frequency. It might be possible to extend that to quarterly moving forward, but it's important to note that LUMOS is designed more from a to be used at a higher level system-wide perspective, or from an organizational perspective, not intended for point-in-time patient care. So, for example, you won't know that John Smith presented to the emergency department last week, but you will know the proportion of your patients that presented to the emergency department over the last 12 months, over the last 24 months, with what triage category at what time of day, at a very high aggregated practice level or regional level, just to give you a sense of the kind of granularity of the information. So to the participating general practice records, we're linking admitted patient data. So if someone was hospitalized, emergency department data, mortality from the Registry of Births, Deaths and Marriages, as well as the cause of death, the New South Wales Integrated Care Database and patient survey. So if someone is participating in a New South Wales Integrated Care program, ambulance data, Central Cancer Registry, mental health ambulatory and non-admitted patient data, which, for example, includes outpatient services at the local health district. So as you can see, a really broad cross-section of services that participating general practices patients access within New South Wales Health. So I won't go into too much detail about this right now, and happy to go into a little bit more perhaps at the end if anyone has any particular questions, but a question that does come up very often is, how can you do a data linkage with de-identified data? And so the way it works is essentially the information that's required for linkage. So for example, names, addresses, and dates of birth are encoded, and the output of that is a filter. And it's the filters that are compared between different data sets, and you might notice the filter only has 20 positions on it. So it's not possible to reverse the filter back to the original value, but what it means is that we can do a very, very accurate probabilistic data linkage without exposing those patient details, which is great from a privacy perspective. So what's included in the data that's being linked? We've covered the data sets that are included in the linkage, but what's actually in those? I'd say the most important information is the encounter information. So when did a patient visit the service? When did they present to the emergency department, and when were they admitted to hospital and discharged? And some contextual information around that. So if they were admitted, what were the diagnosis codes? If they went to the emergency department, what was the triage category? And if they went to the general practice, what are their chronic disease flags? What was their most recent HbA1c reading, for example? That's the kind of information that's available. And so what can you do with that? We'll go into right now. So in terms of the use of LUMOS data, it's available for the purposes relevant to the management, planning, evaluation, and funding of health services. So it's really for higher level use. Again, it's not designed as an information system for point-in-time care. And some examples of that could be planning and evaluating health services, commissioning health services, and potentially predictive analytics and risk stratification. So right now, in terms of the latest linked data, there's approximately 2 million unique patients that are linked, and that represents a quarter of the state, which is just incredible. And if you consider all those different services and data sets that are linked, you can imagine it's a gigantic and a complex data set. So one of our approaches to making sense of that is to use data mining, where we look for anomalies or patterns or correlations. And one of the things that came out of that, or one of the things that we asked of the data, so to speak, is do GP visits show any relationships to unplanned hospitalizations? And based on the preliminary analysis that we've done, what it looks like is that if someone is discharged from hospital and they see their GP within a week, there might be a significant reduction in unplanned hospitalizations over the next 3 months. So the period of significance there is within the first week, and weeks 2, 3, or 4, for example, weren't significant. And that significant reduction might be up to 45%. So that's a very promising insight that gives you a sense of the kind of information that you can get from doing a linkage across the state. And people get very excited about this because they can see the potential. For example, the RACGP or the AMA GPs, everyone really can see that this is really exciting because it starts to create an evidence base that really demonstrates the value of primary care. It helps to demonstrate the value of prompt follow-up in primary care from discharge, and clearly, especially in Western New South Wales, there's things to consider, like distances and access to services will certainly play a part in that. But again, hopefully it just gives you a sense of the kinds of insights that can be derived, and we're really just scratching the surface. So from a general practice perspective, again, so your participation is voluntary, But when you do participate, what you receive in return is a report twice a year after each linkage that gives you information about your patients and the services they access that you might in turn find insightful, or that you might be able to apply in your practice. And really, it's information that's available for the very first time to general practices, because even if you look at discharge summaries or whatnot, it wouldn't be possible to build up a view of all of your patients and all of the services that they've accessed that this can provide. And it's very long, it's 26 pages. It gives you some great demographic information to put your report in context, and talks about some of the linked data assets and visits across services. And then it does some deeper dives into emergency department presentations, hospitalizations, and a condition in focus, along with some additional information to help you interpret the report. And I'm not going to go through the whole thing tonight, but what I would like to do is just focus on 4 key insights from that report that you might find interesting. And before I do that, I think it's important just to recognize that every general practice is different. And in terms of interpreting the reports that practices get, that context is so important. So if you're a practice that visits a lot of residential aged care facility patients, or if you're in a regional area, or if you have a particular specialty like women's health or mental health, or if you're a solo GP versus a large multidisciplinary clinic, your report is going to look different to everyone else's. So recognizing that, it's really for you to interpret and apply. So what is some of the information that you would receive, and how might that be useful to you? Well, if you look at the chart on this screen, what it shows is the proportion of patients in your practice that are flagged with a chronic condition and compared to the your region, Western New South Wales PHN, and all PHNs, so across the state. And you might be thinking, well, I already have that information in my practice software. But what's unique about LUMOS from this chart's perspective is that you get that regional comparison. And why that's important, or why that's useful, to give you an example from a GP that's used this information from a very early stage, was they noticed that their proportion of patients flagged with chronic kidney disease was much lower than their region. And so they considered maybe there was an opportunity to look at patients in their system that were indicated to have CKD but weren't flagged. And so they were able to do that and bring in some patients for health assessments or other things like that. But it was this report that was the impetus for them to do that, because they had that contextual information more broadly. And so then, depending on the context of your practice and your patients and their demographics, perhaps you'll identify opportunities to run disease-specific clinics. Again, it would be really based on the context of your practice. Similarly, another chart that's provided is similar, but from the perspective of the hospital. So for your admitted patients, what was their primary diagnosis for a select group of chronic disease categories? And again, with a regional comparison. So you could use this information in a very similar way to identify potential cohorts of interest, and then use that information accordingly. There's approximately 50 conditions that someone can have recorded against a hospitalization, and you'll also receive the information for those secondary diagnoses as well. But the primary one really is interesting and perhaps most relevant. So from a different perspective, in this chart, you can see on the x-axis along the bottom, the hour of the day, and going up the y-axis on the left-hand side, you'll see the number of ED presentations. And what the chart represents is the activity of your patients in the emergency department grouped by triage category. So two broad groups, triage category 1, 2, and 3 in blue, and the pink line is the triage category 4 and 5. And perhaps where the biggest relevance is for general practice, not to say by any means that a triage category 4 or 5 implies something that could be, that may have been a general practice type encounter. It certainly might not be, but at a very highly aggregated level, what you can do with this is if you notice particular spikes of activity for those triage category 4 and 5 presentations that might be relevant to a general practice setting, you might identify opportunities to, for example, if you see a spike at the end of the day, to look at after hours service provision, or maybe in the middle of the day, it relates to, for example, closing for lunchtime. And one example of a practice that's used this information recently is that they had a spike at the beginning of the day, just before the start of business hours. And so they're considering putting in place a nurse-led, I suppose, team or a clinic, whatever you want to call it, to help triage patients coming into the practice at that very high time of demand, so that they can be seen by GPs more efficiently where relevant. So there's a lot of different opportunities, and again, I'm very conscious that practices close to town are going to have a different interpretation of this report than ones that are in a more regional or remote setting. So that's why it's so crucial to interpret this, within the context of your practice in your region. So this may not be relevant for everyone by any means, but for some practices, it very well could be, in which case it's very useful to them. One last example, again, is looking at, of your patients, when did they last see you in the practice relative to their most recent hospitalization or ED presentation. And this came from a GP request because in previous versions of the practice reports, we were putting out information like, well, this is the proportion of your patients who visited the ED within the last 6 months or the last 12 months. And the GPs wanted to know, well, when did they see me? Did they see me before that? Did they see me after that? I would like to know that information. So this is our attempt to be able to provide that. And so the way you would interpret this chart is on the very top line in yellow, that represents the practice, and then the green line, the PHN, and each of the boxes represents the proportion of patients who visited within a certain time frame. So on the left-hand side, it would be the one closest to the little house that represents the encounter would be 5% of patients visited 0 to 2 days before the most recent hospitalization. On the right-hand side, you'll see the circled section shows that 6.9% of patients visited the practice in 3 to 7 days after hospitalization. And then if you compare that to the region or the state, it might be interesting from the context of your practice to try and understand why that's the case. Is there opportunities to explore the process of post-discharge follow-up with your PHN and your LHD? Does the hospital have your up-to-date contact details? Could be something to consider. Are there ways to facilitate that post-discharge follow-up? And it sounds, and I realize it seems overly simplistic to say things like that, because these are very complex challenges to solve and also very contextually dependent again. So the information is there for you to interpret. And in many instances, you might find this extremely helpful in your own practice. So I suppose because we didn't take questions throughout the presentation, we've been quite efficient in going through those slides. So I'd really love to hear from the audience. If you have any questions or comments, please do share them now. We've got plenty of time for discussion, and I hope you found that helpful in terms of understanding the program, why it exists, and should you want to participate, what the benefit to your practice would be. And thank you very much again.
Thank you so much, Adrian and Jen. There are a couple of questions coming in, and I will encourage anyone to pop your questions in now, because we certainly do have time to cover them. I've got Natalie, who's from the PHN based out in Broken Hill, who looks after 4 practices that border with Victoria. And a large number of patients from these communities visit and are transferred or referred to Victoria for care. Is there a point when data will be available from other states, which would be useful for these communities?
Yeah, great question, Natalie. So I suppose in New South Wales, we've got lots of areas that have cross-border flows. The ACT is a big one, all the borders really. And so what will be included in LUMOS is the information where a patient has visited one of the participating practices. So if it was in Broken Hill, one of those Broken Hill practices that might participate in the program, and then any New South Wales Health Services that they've also accessed. So it won't capture anything out of state, unfortunately. So there would be a gap, I suppose, where there are cross-border services, but where they have attended New South Wales Health Services, you'll definitely see that.
Thanks, Adrian. We've got another question from one of our GPs in Orange, wondering how is LUMOS used within the LHD?
That's a very good question. So I'll just go back to the slide for use. I suppose there's a couple of things that I'd like to touch on there. And the first one is pretty much to this point in time, the focus of the program has been on the implementation. So developing the ethics, the governance, the technology, and the partnerships to enable the program. And now we're at a point in time where the focus is switching to benefits realization and analytics, and really driving use and uptake of the data, both from a program perspective and also from users of the data, like, for example, PHNs and LHDs. So in terms of how LHDs can use this information, a really good and obvious example might be to perform a regional needs assessment. Some LHDs might be interested to understand the characteristics of patients that drive service utilization, and identifying opportunities to potentially address those. And really what we hope is that PHNs and LHDs will work together in partnership to interpret and utilize the information. One of the things we're doing to help facilitate that is to provide comprehensive data dictionaries, resources, and also a community of practice to help support the interpretation and analysis of the information more broadly with approved users. And it's important to note that there's very strict controls in place so that if you are from an LHD in a particular region, you'll only see the information relevant to your corresponding PHN. So noting that some LHDs, there might be either one LHD per PHN, or there could be 2 LHDs per PHN, depending on the region, that you would only see the information to your corresponding PHN. And also that LHDs won't see the name of participating practices. So only New South Wales Health, the Ministry of Health and your PHN will see your practice name in the data, and that's to allow management of consent, of the generation of practice reports, and interaction with your PHN. So LHDs wouldn't have that information available to them, but they're the kinds of up on the screen. You'll see the allowed uses of that information from a regional perspective. I hope that answers your question. And I would also just say as well, sorry, just to touch on the first point around transitioning from implementation to benefits realization, especially in terms of analytics, is that we've only just started to make the data available for the first time just within the last week or so. And so it's all very new, and I suppose that it's fair to say that LHDs haven't had an opportunity yet to look at this data, and that's something that will happen over the next few months and slowly build from there. So there aren't yet any examples I can give of LHD use because they haven't had access yet. It's also worth pointing out that LHDs don't receive copies of the general practice reports, that they're between your PHN and your practice only.
Wonderful. Thank you so much, Adrian. We've got another question here. It's from Nadine, who's a practice nurse in a solo GP practice. She's asking, what does the practice consent process look like? She understands that the data is de-identified, but what needs to be communicated to their patients?
Great question. I suppose really nothing, in that there is ethical approval for a waiver of individual consent. So because it is de-identified, it would be a similar scenario to any other use of data in a general practice for, I suppose, similar to other de-identified data sharing use. So typically when a patient joins a general practice, for lack of a better word, as part of the new patient form, oftentimes there's a question around use of data for example, population health planning. And should a patient wish to opt out of their data being used for those purposes, and should the practice follow up with that request in, for example, the PenCat software or the Polar software by opting those patients out, they will be excluded from the data extraction for LUMOS. Now, even though there's no requirement to give or to collect individual patient consent, it's really important that people are aware of LUMOS and how their data is being used, which is why we are investing in the well, not only things like the privacy impact assessment, but working with consumer representatives in order to develop patient-facing materials that explain in an appropriate way what LUMOS is, how the data is being used. And so we have, for example, on our stakeholder reference group, a representative from Health Consumers New South Wales, as well as 4 other individuals as consumer representatives across our committees. And so one of our activities for 2021 is to work with those people to build up, again, those materials so that we can more easily explain more broadly the purpose of the program and what's happening, and we can make those materials available to practices to share. And whether it's a poster or a brochure, I don't know. I'll be informed by what's most relevant to from a consumer perspective. And so from a practice perspective right now, in terms of consent, you would need to read the consent form and understand it and agree to it. And that's something you can follow up with the PHN. They'll take care of that process. But really from there, we've tried to make it as light touch as possible so that it doesn't disrupt your general practice operations. And there's nothing you really need to do except for, I suppose, reading your report and acting on it should you wish, would really be like the minimum thing. And that's about it. Hopefully that answers your question.
Thanks so much, Adrian. We've got another question here from Alex in Orange. How is data quality and data cleanliness accounted for in LUMOS?
That's I'm laughing because that's a fantastic question, and it's probably something I could spend days and days talking about, and very passionate about it. But I suppose at a high level, what I would say is that there's no such thing as a perfect data set or a perfect data source. And whether it's information from a general practice or from the emergency department or from the ambulance, quite frankly, none of it is perfect, quote unquote, but what it is quite complete and very useful, that being said. So then how do we potentially address data quality issues that are identified? Well, there would be a few different ways, and it would depend on I suppose, the data quality issue itself. So it might not be, it could happen at the data entry level. So what information someone is putting into their system. It might happen at the data extraction level. So the logic behind the way information from the various systems is extracted might determine some of the data quality. How the linkage is conducted and the accuracy of the linked data and the appropriate matches. And then also in the final transformation and processing of the linked data asset, there's further work that would happen. So there's a lot of different parts of the process that would determine maybe the final output in terms of data quality. So it really depends on where, if a data quality issue is identified, where in the chain that it occurs, and then we would need to figure out the appropriate action from there. And I guess without going into too much detail, I hope that answers your question, but basically to say that it's a complex thing, and it depends on the data or where it comes from. But where there is maybe an identified issue, it might be potentially raised up through the data governance committee for a discussion on the best approach to resolving it. It could be liaising with an IT vendor to rectify data extraction issue, or it could be providing information to the source of the data around potential data quality issues, and so that they can change their processes over time. Yeah, I'll probably stop there. And
fantastic. Thank you, Adrian. I'll just give people a couple more minutes if there's any final questions. But it seems like we've covered a lot of bases there, Adrian.
Yeah, a really excellent discussion and questions so far. It's great. Keep it coming if there's any more questions.
Absolutely. Yep. We've got some thank yous coming in. So we've still got plenty of time if people do have questions. I'll just also let everybody know that if post-webinar you need more information or have more questions, please don't hesitate to contact the PHN, your practice support or improvement officers, or even via our team if you need someone to reach out to. We're always more than happy to help. Okay, so a few more thank yous coming in. Thank you everyone for joining us. I might just bring up our evaluation screen while we give people some time to put in final questions. But we'd really appreciate your feedback on tonight's session and the information you received. So if you can take a moment to scan the QR code with your smart device and do the Survey Monkey. It shouldn't take more than a couple of minutes. There'll also be a link sent in a follow-up email if your smart device isn't handy. So we always appreciate your feedback. Any suggestions for further information that you might need in regard to LUMOS or any other topics. So yeah, if you can take some time to do that, that would be wonderful. There's no more questions coming in, Adrian. So I think we're going to give everybody an early mark.
An early mark, yeah. Well, I've got to say that was a pretty rapid presentation. So again, thank you so much to everyone who attended, and I'll certainly stay on the line in case there are any final questions that come through in the next few minutes. And thank you very much, Katie, as well for organising this. And yeah, encourage you to reach out to your PHN for more information.
Thank you so much, Adrian, and to you too, Jen. We really appreciate you being here tonight.
Thanks so much for having us, Katie.
Look, here's another question, Adrian. It might be outside the scope of LUMOS, but it would be helpful to get an idea of what a typical patient journey might be over a year.
That is a phenomenal question, and it's something that we have explored in the data over the last couple of years even, and it's so complex to answer, and it seems quite so I would say it's a very easy question to ask and a much harder question to answer, and the reason is there's so many different, I suppose, combinations and permutations of the services that people would access and the order in which they access them as well. And then the question becomes, well, how do you define a quote unquote typical patient journey? And you sort of almost have to restrict it to like a series of events within a limited time frame. And to give you an example of that, it's why in the practice report example that I just went through, I'll just go back to the slide, around patient journey post-discharge, we're looking at the most recent events around, the events around the most recent interaction. So whether it was an ED presentation or a hospitalization, just I suppose as a starting point. But when you want to say, well, what's a typical patient journey? You could define the patient journey in so many different ways. You know, is it around, do you center it around an event of interest, for example, a hospitalization? Do you center it around something with a broader context, like patients who have died, and then what happened, the services that happened before that? Do you look at within a certain cohort of patients or a regional context? Because a patient journey in Lightning Ridge is going to be different to a patient journey in Surrey Hills in the city. And so it gets, it's such a fantastic question, and it kind of gets to the crux of, well, what is a patient journey and what does that actually mean? And quite frankly, I don't have an answer for you because it can be defined in so many different ways, but I would say that it's something that we've grappled with from a mathematical perspective, from a statistical perspective, even from a philosophical perspective of what's a patient journey and even what is a relevant sequence of events. And then do you want to look at everything that's happened for each individual patient? And then if you do that, because it's de-identified, what can you really do with that? So you almost need to look at it at an aggregated level from at least a practice level or a cohort level, in which case, because everyone's journey is so different, again, you need to like find out, well, what is the question that I want to ask, so to speak? What would I want to know from understanding that journey, and then restrict the analysis to try and answer that question. So if for example, maybe an example might be, well, maybe the term is contentious, but you want to look at potentially preventable hospitalizations and services around that, or you might want to look at patients with a particular chronic disease and service utilization around that. Or if you're trying to commission a health service and use this information to inform your needs assessment, it might be understanding, well, what's the difference in service accessibility for someone in a regional location, and what's for example, the average time it takes someone in Broken Hill to get to a service compared to maybe someone in a more regional a more metropolitan setting. So many different considerations there. And I'm very mindful I haven't answered your question whatsoever, but I hope I've given you some thought around, well, yeah, it's quite complex and very interesting, and we've even had an attempt to try and visualize the patient journey, and again, it's pretty challenging.
I'll just, Alex has just replied to that question, Adrian. He said he think it would probably need to be restricted to certain common conditions or chronic conditions like type 2 diabetes, chronic heart failure, or chronic kidney disease. And then he's made a further comment that service accessibility is really the main thing he was thinking of in that question.
Yeah, definitely. Yeah, appreciate both of those comments.
Yeah. Wonderful. Thank you so much for all the fantastic questions.
Yes,
We've got 5 spare minutes. Thanks. Lots of thank yous in here, Adrian. We really appreciate all the information tonight.
Oh, great. Well, you're welcome, and thanks for such great questions and discussions at the end.
Yeah, and look, I think we've probably given everybody ample time to ask any of their questions. So if there is nothing further, thank you to everybody for taking time out. I know it's December and it's the end of the year and it's the end of a really, really busy year. So we really appreciate you joining us tonight. Thanks to Adrian and Genevieve. And like I said earlier, please reach out to the PHN for any further support or any further needs that you have. We're always here to help you out. Have a lovely evening, everybody. We'll see you next time.
Thank you. Bye.
Thanks, everyone.